House here. So, Eileen, I will let you take it away.
Well, thank you. And I'm going to apologize to everybody that I'm actually chairing this meeting at the Omaha airport. So if you start getting weird noises, let me know so that I'll make sure I mute myself. But anyhow, we've got some work to do today. And I don't know that we have many introductions, but should we do a roll call so that you you want to go ahead, Mike, and do roll call?
Yeah, sure. So, we've got Eileen here, obviously. Greg, you on?
Hi, good morning, everyone.
Great. Thank you very much. Hung,
Good morning, Hang Chong board member.
awesome. And Doug, are you here?
He was.
As I say, I thought I saw him pop on for a minute.
He must have something must have happened. He dropped off, but he was here, so I'm sure
Okay.
he'll
Yeah,
pop back.
we'll circle back for him here.
Okay.
And then from the HCA side of the house, Mike Neuenschwander, PDAB director. We've got Simon over here, our policy analyst, Michael Tunick, our AG, Marina Suzuki, our health economist, Kelly Wu, our data guru, Jinping, our other data guru. And I think that's most of the people from the immediate team.
Okay.
Anyone else I missed?
Okay, so then do you want to give your report, Mike?
Yeah. Let me pull up my little list here. So great to have everyone out here today. We are just kind of thing of note. We're still missing our fifth board member. However, good news on that front. A new HCA director has been found, and I believe he starts August 18th, if I'm not mistaken. So a little bit of time. And I think he's coming out of Maryland. So that'll be good to get to know him and hopefully be able to introduce him to our work. And then we actually just had a little chat with Marianne here this morning. She popped in before she had some meetings that she had to run up to. So working on keeping her seat warm for her, and hopefully we'll see her back here in the not too distant future.
Amen.
Yeah, no, that'll be fun if she can come back. Just some general budget updates. Things have kind of calmed down here a little bit since the spring. And so we haven't had any big shakeups to our program or impacts to staffing. The data team's done some, just like a reorg in terms of where they're located at, but they're still working with us, and the relationship there hasn't changed. We've had a small decrease to our budget, but nothing significant that would impact current operations. So that's pretty good news with how everything fell out with that. Colorado lawsuit, I know we talked about this last time, just the district court dismissed that lawsuit against Amgen, ruling that they didn't have any standing. No other updates on that I'm aware of right now. Some other interesting state updates for other PDABs. So Colorado had their second rulemaking hearing, I want to say last week, about upper payment limits for Enbrel. So they're still working on that. And so be very interested to keep connecting with them and seeing how that's going. Oregon, they're currently taking public comment and going through some of the drug reviews that they've done. I want to say I was looking at their recent agenda that's coming out for tomorrow, and they were going to go over 6 drug reviews in their meetings. And so just the initial view that I got of their reports looks interesting. I think that'd be something good, Simon, we can forward to the board members so you can take a look at and see what other states are doing. Maryland, I believe, also has a meeting coming up, I want to say in August. I have to go back and double check, where they're doing also 2 cost review studies that they're going to go over. Some other things of note, both the Oregon PDAB director recently moved on to a different position, so they're looking to fill that. Colorado PDAB director switched, and I think that we had a new one come in a couple months back. So just some interesting stuff going on there. And then the New Hampshire PDAB, which was very relatively new as of last year, has been basically disbanded due to just the budget cuts that their state was going through, and just some of the programs were eliminated. So some just interesting news of PDABs around the country, things that I've been trying to keep my eye on. And so if board members have any other questions, feel free to ping me. We try and collaborate with the other PDABs regularly, just so we know what's going on and try and help each other out. So, and I think one of the last things on my report, we've gotten a few public comments. We forwarded those to the board to take a look at. We really appreciate people taking the time to write and send us information. One of the public comments of note was a question about some physician-administered drugs being included on the list. And our legislation says the HCA must identify prescription drugs that are dispensed at a retail, specialty, or mail order pharmacy. Sorry, my throat's a little difficult today. Some of these physician administered drugs are dispensed at these specialty pharmacies. So from how the law is written, they are not excluded from being on the drug price list. So we're working to set up a meeting with the group that sent us this comment to walk through some of those concerns specifically, but just kind of putting that out there for the board members of things that we're hearing, and just want to make sure that we're addressing the best we can with any of the public comment. So any questions, thoughts, concerns on any of that stuff that I shared?
Any questions? Don't see any hands. And I see Doug's back on now.
Oh,
so
great. And I do think, Doug, do you have any great, interesting news you want to share with the board?
Yeah, hi everybody. Good to see you all. Yeah, I just had a daughter. She turned 1 month yesterday. So her name is Jo, and so yeah, my wife and I are having some sleepless nights, but it's been pretty wonderful so far. Unfortunately, I don't have any pictures handy, but I'll show you all sometime. Yep.
Well, when she starts crying, you can hold her up for us.
Yeah.
Congratulations, Doug.
Yes, congratulations.
Thanks.
Okay, well then, it looks like we move on to Kelly for the review of the dashboard updates.
Okay, can you see my screen?
Yep.
Okay. All right, so since last time there were some updates to the dashboard that were requested, so I'm just going to go over the updates that I made and spare everyone from going over the dashboard for like the 5th time. So one of the updates that were requested was that everybody be able to view both the specialty and non-specialty drugs in one tab. So before you can only aggregate by like one type. So this is what it looks like. And we changed specialty to like biologics instead. So instead of saying like specialty or non-specialty, it's now like biologics or non-biologics, because that was actually like how they were classified. So now when you go to the aggregated list and you can filter by all. And then for each rank, so this is just like top 25, not like their weighted rank. So by each rank, you can see like each biologic and non-biologic drug in that rank. So yeah, that makes it like pretty easy to see like the top 5 for each category. And then the main reason why the requested update was made was so you could see like all the visualizations together for the biologics and non-biologics, so you could compare. And so this is what it looks like now. So they're color-coded. Orange are biologics and blue are non-biologics. And I know it's like kind of hard to see the smaller bars because that's just like how big the range is for the data. And I decided not to add any annotations. It was just going to be too messy because there's so many small bars. But if you can't see the bar really well, you can just hover over it and it has like a little pop-up that shows the data for that. And yeah, that's the major changes for the dashboard. Any questions or comments?
I'll just say that I don't think we have to, the small bars are not the ones we're worrying about. It's like we're more focused on the high costs. So that I don't think we have to worry about those. Any other comments, guys? No. Okay.
Good, thanks.
Okay. Then we're gonna now we get into some meatier stuff and try and talk about which drugs we're going to determine to have the reviews done on. And I'm not quite sure how we want to. I guess everybody maybe just want to start out with your ideas and comments of when you've looked at this, because I'll say I went through and kind of have starred what I thought was my top picks, and I'll find out. Well, why don't each one of you go through and we'll say, what we've been thinking or where we're at, unless you have a better idea, Mike, of how we should do this.
No, I think that's a great idea. Because we've already had our advisory board share their thoughts and feelings on the ones that they thought were important. And so, yeah, if maybe go through board member by board member, see
Yep.
what their thoughts are, and then we can coalesce around a grouping here and make some decisions.
Okay. So who wants? Doug, shall we have you go first since the baby's not crying right now?
Yeah, that sounds good. I just had a quick question. So why are there two drugs at each rank on this list?
So those are, for example, the list that we used to have that were specialty versus non-specialty. Now it's like biologics versus traditional or non-biologic. It's basically that those are the top number ones on each of the lists, because you wanted to see both lists at the same time, and so that way all of the numbers right there. So it's basically the two lists on top of each other, but then you can compare the numbers all on the same column, stuff back to back.
I see. Okay, thanks.
So yeah, because on that filter, if we went filter by biologics and selected yes, then half of those would disappear, and then if we selected no, then the other half pop up.
Okay, so before I give any drug names, I just wanted to ask a quick question. Are we going to discuss? When I was emailing with you all, I had asked some questions about the aggregation to the ingredient labeler level, and wasn't sure if we were going to have a chance to discuss that issue today. Sorry, I should have brought this up before.
Go ahead, Mike.
I was going to say, I remember I've had a lot of different conversations. So maybe what were the specific questions again to help refresh my memory, and then maybe Kelly can answer some of those on the how and why everything was added the way it was.
Yeah, so basically, this was all in my email on June 5th. And there was so essentially the root of the issue was that before we did the ranking, we aggregated all the products to the level of ingredient and labeler, and I was just trying to figure out the justification for that. And so I kind of outlined some questions for that in that June 5th email. And it's sort of one of the root questions that I didn't understand was if we were to impose an upper payment limit, would it apply to all labelers or just one? It's kind of just a factual question. So Yeah, I'm sorry that to kind of derail our discussion of the drugs in the dashboard. But I did want to get some clarity on that, or at least have a plan to discuss that in the future.
Ellie, do you have?
Yeah, I don't know if Ryan is on, but I thought our original justification for aggregating is we wanted to because like the original when we did not aggregate, like a lot of the NDCs were kind of like from the same group. So then we wanted to aggregate so we can get like more different groups on the list. And then as far as my understanding goes, and other people feel free to chime in, when we do like the upper payment limit, it would affect like all the NDCs on the labeler code and generic name, which are already on our list. But I don't know if the others think we're gonna like grab other like NDCs in the labeler code and generic name not on our list.
So I should have clarified. I understand why we aggregated to the ingredient level. But then the fact that we also require same labeler at the level of aggregation, that's the part that I didn't understand. I thought that it would, I thought we would basically just be looking for all the drugs that, all the products that had that ingredient.
Yeah, I think that would be a better question for Ryan, but I know like if we also aggregate by labeler code, like the products are like they're from the same manufacturer, so that would make more sense than like grabbing like the entire like generic name, like entire group of drugs from that ingredient name. But yeah, I'll let someone with more expertise chime in on that.
Doesn't look like
Yes.
Ryan's on.
Yeah, no, him and Donna are on leave today, so yeah, our pharmacy experts are out right now. But I think in terms of like the UPL, because just the way the pricing, I think doing a UPL across the entire ingredient would be a lot more difficult. And we can have that a little bit more because UPLs are kind of down the road here a little bit. So there's not like an immediate we need to resolve this like right now. But yeah, I think we can dig into that discussion of exactly how. I mean, because creating the whole, for example, Colorado's doing their rulemaking on UPLs, and I mean they're taking a few months here to do that. So it's not a quick and easy thing that they're applying. So
okay, yeah, and I think I agree that I think we can still choose make our selections for affordability review today. But I think I don't know if we could put this on the agenda for the next meeting, or I mean I'm happy to resolve it via email too. I think like I said that my email on June 5th outlined my views fairly clearly. And yeah, basically like I just, in my mind, I can't really think of any justification for why a UPL would only apply to one manufacturer, because it seems like that could cause up a couple other problems. It would, just in terms of fairness, other manufacturers could then raise their prices to replace the manufacturer who is subject to the UPL. So this seems like it would be unfair to the manufacturer subject to the UPL and leave us vulnerable to lawsuits. And then also in terms of gaming the system, the manufacturer who faces a UPL could game the system just by shifting their manufacturing to a partner or subsidiary that's not subject to the UPL, and then just keep charging the prices that are higher than the UPL. And so that's why it just didn't make any. I still don't really understand why we would have this aggregation at the ingredient labeler level. To me, the labeler or manufacturer, I don't understand why that's relevant. So this is going to be. Again, I don't think it's that much of an issue, especially at what we're doing right now. It's only going to be a problem if there are multiple manufacturers of a drug, and so it would be for generics. But that said, this is an important part of our methods, and we have to be able to justify the decisions that we made. And so I think it's important that we reach some clarity on what the justification for that decision was.
Okay. Yeah, we can circle back in terms of UPLs and
Yeah, and it's not necessarily just I mean, like I said, I don't think it's we can choose drugs for affordability review now, but it's not just an issue for UPL. It is an issue for how we made this ranking, right? Because all of the data that defines each of the uh, items on this list. I'll just call them, so each of the drugs on this list, those are, if I understand correctly, those are each row is an ingredient labeler. It's not just that ingredient across all labelers, that's an ingredient labeler. And so it will affect this as well. Is that, Kelly, is that right?
Yeah, that's right.
Mike, I can maybe chime in here.
go for it.
Yeah, so the rulemaking for the UPL that's coming, so we don't have exact rule how it's gonna be applied yet. But in terms of the affordability review for selecting drugs for that, they have to meet the statute criteria, which is the price cutoff and the price increase. And I remember either Ryan or Donna was saying that, let's say we have like 3 generic manufacturers and there is one that's just pricing really high, and the other manufacturers not meeting the threshold. And if we just aggregate everything, then the manufacturers putting a fair price will have a good, standing saying that our products didn't meet that threshold, but still selected and have to submit all the information for the affordability reviews. And I think that's why they at least try to do the aggregation by the ingredient and the labeler level instead of the entire ingredients, in case that there are multiple manufacturers or generic companies or biosimilar companies.
So that's a good point. So it's related to the
threshold issue,
to the burden and the burden on a
Affordability.
manufacturer that we impose with the
Right.
affordability review.
Right.
Okay. So yeah, I think that my previous feelings still hold with regard to the UPL, but I definitely take your point with regard to the affordability review. Yeah,
I think you have a good point on the idea of that we might, if we just had one, that they might get somebody else to manufacture. So that's definitely something we should think about. So you want to go on about the review?
Yeah, and I guess and we'll just have this on our minds for moving forward.
Yeah.
Okay. And maybe I'll forward that email, my June 5th email to the rest of the board, because I was just emailing with the staff to try and figure out this kind of like these factual questions around the methods, but I'll forward that to everybody else just so everyone's clear. Essentially what I was doing, I was working on the paper that we're all doing together, and I was trying to I was writing the justification of our methods, and I couldn't grasp it, and so that's why I was trying to figure this out. Anyway, back to selecting drugs.
Can I just add? So please don't reply all to that message. Just under the Open Public Meetings Act, if you are communicating by email, you run the risk of sort of having a forum and taking action. So just to passively accept and read it, that's fine. But please don't start a conversation online.
So I appreciate that. And you're right that I had forgotten that point. So I will not email all of you. But on a related note, when we're working on this paper together, if we're providing feedback to each other on the contents of the paper, do we need to be careful about that with regards to the Open Public Meeting Act?
I was aware that you were working on a paper, Doug. I wasn't aware that it was who is it? The entire board that's doing this?
Yeah, there are many other co-authors that are on the paper, and so those we will essentially I think the entire board was going to be co-authors. I have to look at the list of who responded when, but
I will get back to you on that because I don't want to force you on the spot to start doing things in the public forum, but my inclination is that if you're at least doing things sort of as members of the board, that at least sort of the conservative approach would be to try to do this
during the meetings.
But yeah, I don't want to. I will get back to you if that's okay. Just because it does concern me.
Okay. Yep, that's fair. I will. I'll be conservative on that until I hear anything else from you.
Okay, thank you.
Okay, but back to the discussion on the drugs for affordability review.
Okay. Sorry, I derailed us a bit there, but I just wanted to, make sure that we had some discussion of that. Okay. And last time we met, we decided it was going to be 3. Is that the magic number?
No, we didn't make up. No, we have not made a decision on that. So
okay.
Yeah, I think
that's part of the discussion.
Yeah,
Mike will lobby for the lower number, and I will push him. So see, we'll get to have this discussion.
Yeah, I think the was coming up with a handful that we wanted to put on the list, and then prioritizing them and doing them a couple at a time.
Okay.
So I don't know,
right.
4 to 6 or something like that, and then we'll see how we get through the first couple, and how far we can get down the list.
Okay, well, to me, I see 2 drugs that stand out above all else, and they are Enbrel and Cabometyx. Those are, and I'm using the aggregated prioritized list visualization tab of the dashboard.
What was the second one?
Cabometyx. I don't know if I'm pronouncing that right. Hung, can you correct me? Or Greg?
You're correct, Doug.
Okay, great. Yeah, I mean, I care a lot about out-of-pocket costs, both in total and in average, and those are our leaders in those 2 categories. And so those are the two that I see as sort of having a strong justification for affordability review.
What's our capacity to do the review? I guess.
Well,
I'll
just say I thought that we could come up with a list of like 5, and then prioritize them, and they would then be able to, after we don't know how long it's going to take them and how much work it's going to be. So it doesn't mean they would get through all 5, but just to have it ready. And isn't that kind of the direction you were thinking too, Mike?
Yeah, something like that. And Hung, to kind of answer your question, so part of this in terms of like capacity is, there's some internal data that we can collect on our own, but then we're also trying to submit and get data from manufacturers and do patient surveys and other things. So part of it is just how fast can we get information back, and then once we get that information, then trying to go through it and then put it in a usable format to go into a report. And so as this will be kind of the first time that we're going out and trying to reach some of these patient groups that will be requesting information from manufacturers, a little bit of this is going to be an experiment of seeing how it all goes. So yeah, capacity, I think if we did started with a couple that we're actually trying to gather that info for, And then we'll kind of see how the next few months go. And then once we've kind of got our processes refined and see, okay, this is how it's worked, then that'll help us refine down a lot more our future timelines.
Yeah, this is Marina. I think if we have 5 drug lists with priority, then it's very likely we'll reach out to the top 2 first and see how it goes. If do we have to adjust some information collection process or not? So we have to a lot of the checkpoints to make as well. So I think we'll reach out to we'll start with first or top 2 that you're gonna select today. But if you can pick 4, 5, 6, maybe that's good. Then we can move on if something is up. Then yeah. So that's the plan.
So if life becomes positive and you get to move through, then but we'll at least go for the top 2.
Mm-hmm. Yeah. And for example, if we've hit huge roadblocks and people don't want to submit information, then there's a whole nother process of within the legislation of fines and things like that, or in appeals. I don't really want to go there, but again, just the spectrum of what could happen is broad.
Yeah, and also, if let's say a drug has, expired exclusivity, and if biosimilar comes in or generic drugs coming in during our affordability review, would it change your mind? That's another thing to think about. So.
Just like to complicate things. So, well, Doug, do you want to add any more now, or should we? You want to think about it? We can come back.
Yeah, come back to me. Thanks.
Okay. Greg or Hong, which one of you? Oh, okay, go Hong. I see you got
I feel like we just need to go with the data, and whatever is prioritized, so we're not biased between picking any of them, because some of the comments I've seen, that they made a lot of good cases on like if there's an agreement already, and then would that be picking one, would that incentivize the other one, and so forth. I think the safest bet is just to go with what's ranked. We already made a decision on the weight, and so we just go with the data and pick the top 2. And so I'm trying to look at the dashboard, and I'm still a little bit confused about the filters and everything, but for sure, like Enbrel is listed as one. I think this is filtered as a non-biologic extendee, and that's why it's up there as a non-biologic. But I think if you do it by R, I believe it would be Humira should be the second.
Yes, if you filter by just like click the yes on the biologics, then it's Enbrel, Humira, Taltz.
But this is all biologics.
Yeah.
Right?
Yeah. And then with the nons on the nose, then Standy.
Okay, but if you don't filter by any of it.
Yeah, just put it all.
But the 2 wouldn't be extendee.
So this is not like an overall list, it's just the 2 side by side.
Correct. Right. So what would be the overall list? I would assume it's Enbrel and Humira.
If you scroll to the right, you can see the numbers, in the column side by side.
Yeah, you can see the weighted rank for each.
But is that weighted rank is not overall? Is it the weighted rank of the biologic list and the weighted rank of the non-biologics? So are they directly comparable, that weighted rank number?
No, they're not comparable.
Oh.
Like I said before, this is a side-by-side list, not the overall. And I just realized what is supposed to be the overall is for some reason a copy of the aggregated list, so I need to go back and fix that. But if I don't know if like our overall list is still on the website or you received it before, but that would be the overall list. I can try to find it and pull it up if you want to see it.
Yeah, that'd be great if you could.
But it does seem like Enbrel and Humira are the top two expense wise and
Yeah,
weighted.
I mean, my best guess would be the two. I bet, but we can verify it with the list and getting it. Because the two, I can't imagine even a top 5 would be a non-biologic.
Well, okay, so but then would you go, you got your top 2. Where would you go then after that to add to
I
the
mean,
list?
we go by what is ranked and based on what was weighted, right? And so I don't think we're here to choose one biologic or one non-biologic. I think we just need to go down the list.
I agree with Hung. And yeah, I now looking at that weighted rank column, I realized, yeah, they're not directly comparable. So, okay, great. So this is the,
Just to chime in here though, for the prioritized list, I remember you selected a few factors you want to consider, and these are the ranked list. But 2 things that's not in the rank is the availability of biosimilar or generic drugs, and also the number of the threshold that met for the from the legislation. So that's not really considered into this ranked list. So when you go down the list, if you feel like, well, one drug has a biosimilar already approved or generic drug already approved, you want to skip that. I think that's something, the discussion you need to have, because those are the 2 things previously mentioned that we want to consider, but it's not really in this ranking, just to give you a heads up.
Yeah, I concur. I mean, Humira, there are at least 10 biosimilars, if not more, out there right now. And obviously that's gonna affect many of the other drugs and not just Humira, just because people would start using those over Enbrel and so forth. So it is a complex complicated question. And then, many of these drugs too will have biosimilars coming out soon. And what is that timeline that we are willing to evaluate or take into consideration? Is it 6 months from now? Is it a year from now? And so if it's within a year, do we, say yes or no? But yeah, that would be a significant variable.
Well, and Kelly, this list doesn't have them grouped, correct?
So this was our original overall list of the top 25.
but these are products, right?
Yeah, so this is at the NDC level.
Yeah.
So you wanted to see the top 25 at the aggregated level.
Yeah.
Okay, yeah, we don't have that, but I can work on that if you want.
Well, I mean,
Well,
So
go ahead.
Where's Humira on this?
You might have to scroll up. I think it's a bit at the top.
Okay.
But that's just for one of whatever.
yeah, this
dose.
is the combined list.
Yeah.
One syringe size, yeah.
Yeah.
But I mean, if you look at this list versus if you go to the dashboard where we combined everything, your top 6 on that list are the top 4 on the dashboard. So I think in terms of there's some consistency here, whether you break it out or whether you combine it.
I think you're right. I think you're probably right that we're going we may end up with the same selection. But to Hung's point, we voted, we have this ranking procedure. It seems like if we do anything other than the weighted rank as we said we're going to do, it may leave us it may seem arbitrary.
Well, I guess when I was looking at it, it was the question of, did we want to do like the top 2 from the biologic and the top 2 from the non-biologic to put on the list? I think you can make a case that just the direct ranking doesn't. You could say that they're 2 lists, and that we're taking. You understand what I'm trying to say? I may not be.
Yeah. Well, because that's the way I think we originally, back in the spring wanted to, or late winter wanted to break it out, just to try and differentiate. But again, the top 2 on the biologics versus non-biologics, and then the top 4 on the joint list are all the same.
Right.
So basically, any way you slice it or dice it, the same things are coming to the top.
Can we do 4?
Yeah. No, we can select 4 and then just pick the top, or pick the first 2 out of that we want to do, and we can go from there.
So we'd be talking Enbrel, Humira, Extandia, and Cabometyx, right? Because that's the top 4.
Yeah. And I would take the top 2 from each of the lists, and then they're also still the top 4 when you throw everything together, break it out individually.
So Greg, you should chime in here because you're the newest one and haven't had to talk about this stuff much.
I've been quiet. I think I also agree that we should stick to our methodology, and I think I also agree that whether we merge the list or not, it's kind of a wash. It's very similar information. So I think I like the idea of taking top 4, focusing on the top 2 to start with. I do kind of, as Hung mentioned, the plethora of biosimilars to adalimumab that are out. I do wonder about the utility of that. I don't know if we have any forecasting or if anyone has a better idea. I know kind of looking at some other utilization, it sort of dropped off over time. So I wonder if we're trying to solve a problem that in that regard is already being solved with time. And I think I looked up Enbrel, it loses their exclusivity in the United States in 2027. So I think there's probably some time, and there's probably going to be some litigation, my guess, drag that out. So that still seems like a good target. So I think I like the idea of top 4, focusing on the top 2, and then kind of if anyone has any input about Humira or thoughts about pursuing that, or if it's a good use of our resources or not. It is clearly it's a huge driver of cost, so it's hard. I don't want to just say we shouldn't do it, but want to make sure we think about it.
And one thing too is this isn't our only crack at the at going through the drug reviews. So this year we can try one thing. Next year, we can focus on different drugs, right? So there's this is going to be an ongoing process where we can look at a lot of different things over the course of time.
Yes. I'll just say that as personally, since I worked with MS patients, that it's too far down the list, but I can't believe it's still on it. It's fingolimod, that it's up there because, and then, just get me frustrated. So, okay, so then I guess let me vocalize this and then we'll see if we have agreement that Enbrel, Humira, Xtandi, and Cabometyx, that we want to start with those four. Everybody seem to agree on that or no?
I think I have a couple thoughts on that. First of all, it seems that Enbrel is the clear number one. So if we were going to prioritize, and we are prioritizing,
right?
So maybe that should be the first one we do. But then Humira, given that there are therapeutic alternatives, biosimilars, perhaps should we rule that out? And I'm trying to find the documentation of how exactly when we're supposed to incorporate that information, if it's now or if it's the affordability review. Does anyone happen to know that?
So the way we were using that as a factor to help us select. So if you scroll all the way to the right, there we go. Keep going. There's it talks about, does it have an alternative or not?
Yeah.
There we go. Therapeutic equivalent generic. So that's something that can help us decide, in terms of importance, but not necessarily a thou shalt type of consideration.
Well, I would say that we could since there is a therapeutic equivalent on that one, that we drop it down in the priority list so that it's not the top two to start with. Since if we have concerns that things are getting cheaper. Is that what you were thinking, Doug?
Something like that.
Doug, I think we probably should keep it just to go through the exercise, knowing that if we have four and if we're prioritizing two, we can perhaps Humira would not be in the top two, but I like the team to do some work on it and just to give us a good exercise to thinking about generics or alternative availability and so forth.
So go ahead, Doug. Go ahead.
Yeah, I agree. Like, we obviously we don't have to. We can do the affordability review, and we don't have to impose an upper payment limit or whatever. We'll learn a lot from the affordability review regardless. And to your point, having it lower on the priority list, I think would still align with our stated methodology, where we look at the weighted ranking, but then we also incorporate this information about whether or not there are therapeutic alternatives.
So then,
in short, I agree.
Okay, so then I'm going to try to see if it's. So we're thinking Enbrel, then Xtandi, Cabometyx, Humira. Is that in that order?
I like that.
I like that too.
Okay, what about Hong?
That's fine. I mean,
okay.
What about you, Eileen?
No, I had my little star. I had 5 stars, and you've got 4 of the 5. So that's
what was your
fine.
5th?
The last one.
My 5th was Cimzia, which I can't pronounce, but which I don't know where that's at now in the consolidated list. Number 5. Okay. So, yeah. So then, all right. Do we? I guess we probably need a formal vote. Does somebody want to make that motion that those are the drugs in that order, and then it's
Move to approve.
okay. In a second.
Second. Yes.
Okay. All those in favor?
Aye.
Okay. We've got our first 4 drugs. Does that take-
Way to go, team.
Yeah, really. Does that make you happy, Mike?
Yeah, we're moving up the road here. So
So, okay then. Then I don't. I mean, we've got plenty of time. Does it? You want to have any more discussion about if we wanted to think about the next steps or when we would? Oh, somebody wants to know the four drugs again. Enbrel, Humira. Oh, it's not in that order. I said it wrong. Enbrel, Extandia, Cabometyx, Humira.
Eileen, would you redo that vote in a roll call? Because my recollection is that the procedures are for a roll call vote, not
Nope.
yeah.
Okay. So, all right then, Mike, you can. We've got the motions on the floor. Mike, you want to do a roll call?
okay, Eileen, yay or nay?
Aye.
Okay, Greg,
Aye.
Doug,
Aye.
Hung.
Aye.
Okay, there we go.
So moved and passed.
Our AG is happy.
All right.
That means
Got to
we're-
keep the lawyers. Got to keep them happy.
Great. Okay.
I have a question.
Oh, Doug?
So I guess this is for Kelly. Should we expect the aggregated prioritized list on the dashboard to change to reflect the sort of the combined weighted ranks?
No, I don't see like any way to add it into our current dashboard because like the all already reflect like both of them side by side. But I mean, if you want to see it, I could make another tab or send it out, but there won't be any new data there. It'll just be like a handful of drugs from each list that make up the top 25, if that makes sense.
Kelly, can you
Um,
combine that and then just do the top 25 for us to see?
Yeah, I can generate it.
Okay.
Don't sound so excited, Kelly.
She's like, we've done this before. You guys had me change this.
I know. That's what we're here for.
Kelly's a good sport, so.
I know.
But
Just-
and I mean, I think like it's important to remember that we want to. We're not done with this, right? We want to have this. We'll use this prioritization again. Next year we'll want this reference for for looking at when we do the affordability reviews, and it's a really good resource for the public if people want to go on here and see, okay, what's expensive in Washington State, and so we want it to. We want to get it right.
Yeah. Well, and that's the thing too is because this is the first time we're going through all this, we've been honing and refining and tweaking and trying to figure out what we want. Next year, it's going to be a lot easier because now the dashboard's up. All we have to do is update the data with the latest stuff. And so, it'll be a whole lot easier to go through this whole process because now everything's created. It's just a matter of inputting new data. So yeah, this will be a resource that we continue to use moving forward. So it's a good one to make sure we have it tweaked just right.
So do you,
I have just a quick question. So speaking of the data and refreshing it, when do we get new data? Is that database, is that updated as new information comes in? And so going back to the Humira example with alternative, you would imagine that number is going down. And so how do we stay updated on that information? Or is it twice a year, once a year that database get updated?
Yeah, so the goal here is, again, once we get our process down and everything's kind of streamlined and refined, is once a year, every summer, basically update the data. Then that starts a new, okay, let's select our drugs for the year. And again, the dashboard and all this should be new and easy to basically just update. And then we select the drugs, and then we start doing the drug reviews through the year, and do our drug selections. Eventually with the UPLs, do our any UPLs, and then the next summer start over again. So once we get through this first drug review cycle, then that'll kind of be the new norm that we're trying to establish, is just kind of going through updating everything once a year, selecting the drugs, doing the drug reviews, doing the UPLs, and then starting over again in the summer.
So our years are more like fiscal years rather than calendar year.
Yeah.
If that helps for you to think about it. Okay.
Yes, and also just to add to that, let's say if we are implementing UPLs, then we have to kind of review how it's performing as well at some point. So that's gonna be part of the cycle too. So whether we are gonna select new drugs every year, I think we have to see what happens from here. And just to give you a more realistic expectation of the timeline, so for the Colorado, they took like 7-9 months just to do the very first drug. Now they are scaling up, but it can be a slow process depending on how the information collection will go. So just a heads up, don't expect everything will come back in 1 month because we need time to gather the data and also to analyze and to write up a report for you. So we'll see how it goes. Yeah.
So Han put the list of the 4 drugs in the webinar chat, but it's not in the order that we said. So just want to clarify so that we don't have different expectations. The order was Enbrel, Xtandi, Cabomet, Xtend, Humira. Right. So I'm correct, aren't I, in what I just said?
Yep. At least that's how I got it written down.
Yeah. Okay.
Thank you. Yeah, thank you for the prioritizing that.
Okay. Just want to make sure that we get all of our T's crossed. Okay, then Marina, we can move on to the next steps.
Okay, let me see if I can share my screen. Let's see. Okay, let's see if it's coming up on your end.
Yeah, we got a pretty picture.
Okay, great. Is the document coming up though?
Yeah, now it is.
Okay, good. Okay, I don't know. This is in a way somehow. Oh, here. Okay. Okay. So just a few updates for the next step, which is the affordability review. The form has been updated for all stakeholders, but the one with significant update is one for the manufacturer. So I just want to share what happened to this form. Let's see if I can do 2 pages side by side. Yes. Okay. Yeah, so I got some numberings based on a recommendation from Michael. And then we got more detailed instructions set up here. What to do with this form for the stakeholder. And then if you look at this table of contents, so one big change that happened is that we removed the pricing in the other foreign countries. So that the whole section is gone under the drug price information. And also we don't have a section anymore for the advertising, marketing, and lobbying cost. So that section is also removed. And also we changed the preference for the foreign HTA or health technology assessment information because ICER is the US organization. If we have a review from ICER, then it's optional for the other foreign HTA review information. So those are the new changes. One thing is though, under the research cost, let's see. Yeah, for the cost of research and development, we separated out the funding sources and other cost descriptions. Originally, we thought, well, the funding sources, this is going to be a required section, and R&D cost descriptions, this is going to be optional. However, after discussing with Michael, his recommendation was to keep this required because this is the information that we cannot look up. And also the data from the DPT program, which is our sister brother program, is not detailed or sometimes missing because it is an optional information from for the DPT. So that's there as a required section on this form. And we added a language saying that if the manufacturers cannot provide it, then they can just put it's possible to omit certain sections if they cannot provide the information. So those are the changes on this form. And one question we had was, so to make some sections optional, yeah, we are allowing the optional sections if we can look up information from the public-facing platform. And one thing that came up is for the federal pricing and also the CMS pricing. We can look it up, but we don't have good way to pull any historical pricing information. So a lot of pricing information we have here, we are doing like the last 5 years so that you can see the trend, whether it's increasing or has been stable. But the exception is going to be the federal pricing and the CMS pricing. So those are the ones we are not likely to pull on our own. We can get the current pricing, but if you need any historical information on those to see any trends, then we have to make it required rather than optional. So I just want to hear from you. Do you think you'll need the historical data on the federal pricing or not?
It's a good question. What do other members think?
So that's usually under the discounts. Let me go to see that portion. It's page 9. So it's currently, I have it as, yeah, so it's under this discount section. So the information we're trying to get is the federal supply schedule pricing, the big 4, which is the VA pricing, DoD, Coast Guard, PHS. So these are the big 4 pricing, and also the VA national contracts price. So these are the ones, the federal pricing we can pull for the current one from their website. But if you need like a historical like trends or past information, then it's something we kind of have to ask.
So the questions really is, are we going to be needing historical trends?
Yeah, exactly.
When we get into upper payment level discussions.
Right.
So what do you guys think?
So just to be clear, when we should be thinking about this information as being useful for both determining unaffordability and in our decision about setting a UPL.
Yes.
Yeah. So do you think that I guess I would say I don't know whether that the historical information is necessary.
I think my advice is if you're not sure, then let's ask it for the first time and then see if it's going to help you or not. Rather than, like later saying,
That's true.
we have like, past data to see, how it changed, then we have to go back to the manufacturer and ask again and wait for it, for the data to come in. So
what do you guys think?
Mike, go ahead, Greg.
I also don't know what I would do with it. I mean, if it were going up or down, because we'd be picking kind of a point in time anyway.
I think, yeah, I think hearing like other states PDAB, this is kind of anchor points for setting up upper payment limit because this tends to be the lowest pricing information that you might get. So it is kind of
Oh,
important, pricing information you might want to hear. So that's why I
right.
just double check with you.
I get it that now. So you're saying that when you would go to setting the upper payment level, seeing how cheap that it actually had been delivered to the VA. That's a good point. So
Usually it's like the Medicare price is like the lowest price that anyone pays the manufacturer for the drug, right?
Right. Yeah. So you might want to know what the CMS pricing, VA pricing in the past and how it's changing kind of might give you some insight. Then we say, that's corrected, even though it's available on the website for the current pricing. But again, if it's not going to be helpful for you, then we can make it optional and we can pull on our own. So just wanted to hear with you, like, what your thoughts are.
Yeah, I can see it being useful because actually, yeah, you can imagine if the price has been going up, then you could say, if we're trying to set a UPL, then we can see, but for 2 years ago they were charging this, and they charged this to CMS, and they sold a lot at that level. Then you might be able to we could use that as some type of benchmarking our UPL decision.
yeah. What do you haven't said anything? No comment?
I'm trying to, like Greg was thinking, I'm trying to how we make use of this, but maybe I'm getting too far ahead of myself. But just, we're talking about there's a piece of it that says the ceiling price for 340B. I mean, it varies between the drugs, and I don't know how it determined, but some of these drugs are penny drugs, right? And so that's not the price, right? Yeah, it's
Well, I think Marina's point about
mhm.
if we're not sure, collecting it to start with may be a good idea. Then if we don't use it, we can take it out.
Yeah, and is it proprietary information and so forth because it's negotiated and
I mean, it's
I don't
information
know.
they publish on the website, so it's not
It's not.
it's not
It's
super
not that.
sensitive
Yeah.
information.
Yeah.
Okay.
So, do we have agreement just to have her leave it in?
Yeah, how many? Oh, so last 5 years is our date range.
Yeah, because everything we are selecting are like 7 years old. Yeah, so I think 5 is
Okay.
enough to see the trend, unless you need the full, pricing information. But okay. All right, I'll change the form on this aspect. I think that's it for the form updates. And I also changed a few, like wording where stakeholder required some clarifications. And again, for some information that they can kind of make it optional, we have a box that they can check a box and they don't need to submit the information, and we'll do our own data pool. So some changes on the form, but yeah, we'll have this reviewed by the agency, and this will be posted on the website later. Okay, so that's one update. And another one I want to discuss today is the patient and expert survey. So let me pull up a document here. Okay. All right. So I did get a few requests on what type of questions you want to include, but the majority of them, something that I screened from surveys available from other states' PDAB, as well as different organizations out there. And I didn't include everything because, you know, a lot of surveys is pretty lengthy. I just pulled whatever seems relevant and rephrase it for our purposes here. So we're gonna go one by one, but the two big questions I have for this survey is one, which questions you want to mandate. Some information is a bit sensitive, like asking for their income level, that kind of stuff. And that could be optional, but any key or essential questions you want to get input on, I think will make it mandate. So that's one question, which questions you want to make it mandate. And another question is, do you want to target only the Washington residents or make this survey available to anyone? And we ask, are you a Washington resident or not? Yes or no, and we can do a subgroup analysis. So those are the two major questions. But as we go through, feel free to add any questions that you want to ask or delete if you think, oh, this question is not necessary. One note is though, still we don't know what kind of formatting is possible in the ServiceNow survey questionnaire. So that's a platform we have to use for any surveys going outside of our agencies. That's like patients or medical experts. And, you know, I'm pretty sure we can do like a multiple choice questions, fill in the blank. But we are not sure if we can do any like scales or kind of complex matrix questions. We can build some logics. I know that. So like, let's say patients ask yes to this question, then we are going to ask these two more questions if the answer is yes to the previous one. So we can do that type of logics. But so don't get hung up too much on the exact wording because we may have to adjust, you know, what kind of formatting is possible on the questionnaire. So, but just focus on the big idea for now, like what information you need from patients and medical experts, and you get to review the exact survey data once it's built into our system. Yeah, so just focus on the big idea for now, like what type of questions you want to ask, okay? So for the patient survey, a few different sections just to point out. So it will be some demographic questions. And then there will be some medication question, what is your medication you've been using, that kind of things. And then the meat is here, the affordability questions. And then there will be some specific questions for patients not using the drug that's like being reviewed, but using something like therapeutic alternatives for comparisons. And then we have questions on the coupon use, questions for the patient assistance program. And then the last one is the free comments. So those are the big sections we have currently. And I just want to go one by one from the top. So let's say for the patient demographic questions, we'll be asking their name, the email, to make sure we don't have any duplicated submissions from one person. And then we'll be asking, let's see, are you taking this particular medication that's being reviewed? Yes, no. And then, are you a Washington resident, currently living in Washington? Yes, no.
Marina?
Yep.
So you just want us to tell you which of these questions you think needs to be mandatory?
Yes, yeah, we can do that later. I just want to go through the questions.
Okay, got it.
So that you'll hear. So thank you for asking that. Yeah, but feel free to chime in if you have any like burning thing you want to add or remove. Yeah, so this is just a demographic, you know, asking name, email, are you a Washington resident or not, where do you live in terms of the zip code, so that we can figure out whether it's in a rural area, kind of underserved area or not. and then just household size, their income, so that we can kind of tie into their affordability, and then the insurance premiums, and whether they have an insurance that's covering prescription drugs, and what type of insurance they have. Is it Medicare, Medicaid, commercial, or are they just purchasing for their self-coverage? So those are the questions for the patient demographic. And then for the medication utilization questions, we have one, again, are you using the reviewed drug? Do you have any experience with other medications that's treating the same condition? And then see what is the most current one you've been using and how long you're using it. So this is just to get some kind of baseline information of their medication use. And I think this is the meat of the questions regarding the affordability. So yes, no question regarding if they have any difficulty affording the medication. So that's the first one. And then more detailed questions are following. So one is, have you ever not picked up the drug because of the concern of the cost? And have you ever delayed picking up or refilling the drug because, again, the concern for the cost? Yes, no. And then have you skipped a dose so that, they can kind of prolong the usage of the medication that they have at hand? So that's another question. And kind of similar idea have you ever taken a reduced dose or amount of the drug than recommended by the doctor because they cannot afford it if they are trying to follow the instructions? And then what is your monthly out-of-pocket cost before and after meeting deductible if they have insurance? And if they don't have insurance, it's just asking what is your monthly cost for the drug. And then the last question is, what is your affordable monthly budget for whatever the drug we're going to be selecting or asking about? So those are the affordability questions. And same questions for people say, I'm not taking the exact drug that's being reviewed, but the therapeutic alternatives. I'm wondering if they have a similar experience here or not. So it's pretty much a duplicated question from the sections above. And then questions on the coupon use. Have you used the coupons to get the medication? Yes, no. And have you had any trouble obtaining or using a coupon? Yes, no. And then what is the difficulty using the coupon? Sometimes coupons have a limitation, so it's just asking for that. And so this is the section for the patient assistance program. Again, have you applied and have you approved? Yes, no type of questions here for the drugs that we are selecting and also for the therapeutic alternatives. And then asking what type of programs they applied for and got approved for. So these are going to be a follow-up questions if they answered yes on the previous one. And then let's see, have you had any difficulty using the patient assistance program? Yes, no. And if they say yes, we can ask, was it the paperwork? Was it the income threshold or something? It just took too much time. So those are the questions we are asking. And then also concerns on the future, because eligibility could change, or whoever the organization offering the PAP program, they can remove the program. So have you any concerns on it? Yes, no. And then the last one is the free comment. They can do more details on the free text. So this is gonna be the last question that we have on the survey. So this is the current draft. And before the agency starts, I actually start building the question into our system. I just want to hear from you. Do you think this is, am I hitting the information that you wanted to ask? Or, let's say you don't need any of these sections entirely, then I have to remove it. Then just want to hear before I do more work on this. So what are your thoughts on this?
I can start, Marina.
Yeah.
The many of the questions are great. This is a very long survey. I mean, we're lucky to
Yes,
get
I think yes and no, because you're seeing the entire list. This will cut off based on, the yes no from the earlier
Okay.
question. Yeah,
Okay.
so they're not gonna have like the whole thing here. Yeah, and especially, depending on which drug they're taking, if they're not using any drug that's under the review, then I think it's like a quarter of the length.
Okay. I'm
Yeah.
just thinking, even if it gets shown by because they pick yes and no, I mean it's still long when you think about a survey. I mean, it's usually
Mhm.
like 10 questions, and anything more, people are just like, I'm not gonna finish this. I mean, that's how I am. Maybe people are more they'll finish it. The other piece too is a lot of these questions they may not know the answer to because like patient assistant program and so forth, a lot of time is being done by the provider office or by the pharmacy that they're getting at, especially if it's a specialty pharmacy, it does many of that work for them, or drug manufacturer would have a hub. And so many of the questions they may not know. So just that's just a comment. I think we'll need time to review this. I would have a lot of comments for this because we do this a lot where I'm at, and so
Yes, I appreciate that comment. And yeah, keeping it short is usually better based on my past experience as well with doing different surveys. And for the PAP, we are asking kind of similar questions in the expert survey that's separate from this, and we're going to go through next. But yeah, and I'm thinking making these sections also optional. They can just skip through. They don't need to answer. I think we have to make the name, email, that kind of questions mandate. And the key question, like this one, have you had any difficulty affording? I think this is the meat of the survey, so making it this mandate. But other, coupon use, PAP is kind of good to know. So having these questions optional and they can skip through if they don't want to answer, that's totally fine. So yeah, we can set it up that way as well.
and we should probably okay, go ahead.
Oh yeah, go ahead.
No, and you probably want to run this through some type of readability score.
Yes, yeah. So we have like a communication team full work on the wording, phrasing, that kind of stuff.
Okay.
And there is like a survey team who is kind of expert building this into the logics and into that system. So we'll be getting their help as well. I just want to make sure before getting their help, I want to make sure that we are capturing whatever you want to ask into our draft so that they can work on it.
And you're saying there's another survey for providers?
Yes.
Okay.
Yeah.
So this is just for
Yeah, so this is just
caregivers.
for the patient caregiver survey.
Okay.
So I'll just throw in that I definitely think we want to know if they're Washington residents, because that's what we're working for, is Washington residents.
Okay, yeah, so we'll make this mandate as well.
And then the other thing I thought, which maybe it's the readability people that'll take care of this, is like you shouldn't just say Medicaid because we call it Apple Health, and some of the patients don't know they're on Medicaid. They think it's just Apple Health.
That's a good idea.
And and in Medicare, it's like they don't know the difference between half the legislature doesn't know the difference between Medicare and Medicaid. So I'm kidding, but still, I think we need to put some describers in there so that they know what you're looking for.
Okay. Okay.
Doug or Greg? Yeah. Any other comments?
Yeah, I just wanted to ask, how are we like targeting respondents for this
That's a good
survey?
question.
Is it just going to be on our website and we'll say, hey, if you have used or used one of these drugs, fill out our survey?
I think other states did just post on the website and they didn't get a good response. So, but I think Oregon, they used that external company or consultant to reach out and gather the data. That's one. And I think I remember Ryan mentioned there is some mailing list that we can use to actively reach out. So that I think we'll do that as well instead of, yes, we'll post it on our website, but I think we have to do some type of active reach out to get some good response. What type of mailing list we're going to use is still a question, but yes, we'll into that.
Yeah. Okay. Yeah. Then that sounds good. I'm just reading in the RCW about where this input is supposed to come from, and it says patients affected by the condition or disease treated by the drug, as well as individuals with medical or scientific expertise. And so given that it says patients affected by the condition or disease, I do think we need to make whatever questions about have you used this drug or do you use this drug, those need to be mandatory.
Okay, yes, that's true.
So, and relatedly, I'm not sure, I guess we could consider input from caregivers, but the RCW doesn't mention that. As opposed, it says we shall consider patients, but
I think that's usually for like any pediatric medication. I mean, the drugs we selected, it's not really that, but in case that later, if there's any pediatric medication, then it might be the parent filling in the survey. I think that's why Colorado named it as patient and caregiver survey, I think.
And then so thanks. Yeah, that's good. In terms of the have you ever used, do we ask them when they used it? Because this will also be relevant to
that's a good question. I think we asked what's the current one.
Rather than how long have you used, it might be better to say check the years during which you use this drug or something like that, and have it go back.
Okay.
Or maybe is a year granular enough? Probably. Yeah.
Okay, I'll do that.
Should we go over each question? I'm just worried it's gonna keep going because I think we have a lot to talk about with some of these questions. So probably give us a chance to kind of think through it and then just provide comments back to you guys on it. Doug has a good question in the targeting. So are we targeting just for those drugs that we have picked to do evaluation on, or is it for open to everyone?
I think the recommendation is to make it open to everyone who's being treated for the same condition. Because if you think about it, if we are just targeting the patients using the reviewed drug, then they kind of find a way, to make it affordable to them, right? So it's possible that some patients not using it because of the affordability concern, and we want to hear from them. So I think we need to be more inclusive, just asking patients being treated for the same condition in general.
So if there's like any patient support groups for the disease, then you'll target them.
Yeah, that'd be a good way to, if we can get some help from like patient advocacy group, having like a mailing list, then that might be a good way to reach out to them as well.
And many of these drugs have many indications, so it's gonna be
I have to kind of
I don't know, think about how
that's a
we
good question.
word that.
Yes. Yeah, like which for which indication are you being treated for, and they have to select.
But the target advocacy group, I mean, if you have a listserv with the hospitals or providers, I mean, they can forward this to their patients, or if they're willing to help and so forth.
Okay, I'm just typing in some notes here so that I can add that later in. Okay. All right. Any other like major input before we start building this into a system for you to do more like a detailed commenting?
Greg, you didn't say anything. You have any comment?
I mean, I was wondering if we could use like the HCA's kind of data to target these patients, if we had contact information for them or people in disease states, if we could do some data mining internally, but maybe that's too much. Maybe just advocacy groups makes more sense. In that it would kind of ensure that we are reaching those patients, that they have these disease states or on these medications, and sort of get around maybe asking some of these other questions, but perhaps it's not appropriate. And then, I just think, cutting it down would be the big thing. I would also agree with that.
Yeah. Let's say they answer no to whether they're a Washington resident or not. Do you still want to hear from them? Should we keep asking? I mean, should we include them, or like?
I don't think so, but
I don't think so either.
Okay. I guess if we're asking help from patient advocacy group, then they may have a mailing list for all the members, but they may not have like a Washington specific list. So I'm assuming just they may just email it, and then for some patients, they say no, I'm not a Washington resident, and we can just end the survey there, or just keep asking questions, and we can screen out on our end later if you want to look at Washington specific response. Either way is fine. Just giving you a heads up that if we are asking help from some external groups, then some patients may not be a Washington resident exactly. So
I think one thing we want to be careful of is not collecting data that we want or can use, because we've got enough data already. I mean, this is going to be a lot. So anything to sort out data that we're not looking for, I think would be important. So, if we're not looking for, outside of Washington, like, I don't know if we want to waste other people's time having to fill out a survey that we're not.
Yeah.
So that's a good point, Mike, because what's the purpose of the survey then? Because, deciding on what drug that we're reviewing and what to put a upper limit payment, how would this help with it? Is this going to be a factor in determining what that amount would be? Or is this just to see how successful the program is? And if that's the case, then I'm thinking a whole different set of questions.
My understanding is that it's part of our affordability review, and so it'll help us determine whether or not the drug is unaffordable.
Okay.
Right.
So that makes sense. And
so one thing I would say about non-residents is, you could have situations where someone, they moved last year, they lived here for 20 years, they moved last year. Or someone who lives in Portland but gets their care in Vancouver, something like that. But these are obviously extenuating circumstances. So,
well, the reason I think it's just Washington residents is the upper payment level is only going to be good for Washington residents.
Is that true? Like if you live in Portland and you buy a drug in Washington, it doesn't apply?
Well, maybe if you're filling it over here.
I don't know.
But
So-
I don't know.
they wouldn't have coverage, right? Because this is through the HCA, so you'd have to be a Washington resident. Is that
Well,
right?
no, it's not just, I mean, the upper payment level would be for those that don't have to be insured by the state necessarily.
It's for all drugs, Greg, I
All,
think.
yeah,
So
Oh, okay.
it would affect commercial
yeah.
and everything because you're affecting the drug cost, the acquisition cost, right?
Oh,
And
that's true.
so it doesn't matter what insurance, that's the cost gonna be in Washington
Well, it does matter. There are some there's a set of insurers that it applies for and a set that it doesn't. But I think we decided it's about half of insured people or something like that.
Yeah, I think if someone wants to give the input, it's hard to say no. I mean, if they're prepared to do the survey and then you cut them off, I'm not sure. But yeah, it's
Well,
I think the only situation asking or getting information from out of Washington is, just the pricing kind of information, just to have a bigger pool rather than, asking Washington residents specifically. You might get just a bigger, I guess, sample size to see the average or extreme numbers. I think that'll be the only
To Mike's point, though, that
thing I guess.
we have great data on costs, on out-of-pocket spending, on total spending. That's not the information that we're going to be using from these surveys. So getting a big sample to get representative data on costs, I don't see that as the goal here. I see the sort of the questions about for people who didn't use the drug because it was too affordable, what did they use instead?
yes.
The anecdotes about unaffordability, that's what I want to see.
Yeah.
So, and I think that we'll do it because I think people are probably, if you're going to go in and fill out a survey, that's probably a story that maybe you have on your mind and you're likely to tell. I think we'll do okay at eliciting that information, but I don't think we really need to worry too much about getting representative data.
Yeah, I think one thing I just want to point out is that our out-of-pocket cost calculation, that's all coming from our Washington State all payer data, claim data. So that's coming from payers, not patients. So one critique, we had from manufacturers is that those out-of-pocket cost is actually could be an overestimate because they're offering patient assistance programs, they can use coupons, that kind of things. So I think getting the out-of-pocket cost from the patients directly, I think that might be a more actual representative numbers. So I think that's the only thing that you might want. Yeah.
Well, certainly asking about coupons is a great point. I agree with that. Yeah.
So do we have, Marina, have we all given you enough information for this time?
Yes, I have an idea which questions to mandate based on your input. And for the whether to collect info from only Washington only or not. So the survey will be available for distribution, but we can cut it once they select no, I'm not a resident. So I can make that structure into the questionnaire. Okay, so that's good. Thank you for the input. But yeah, if you have any additional questions you want to add or any feedback, just feel free to email me, and earlier is better.
Sorry.
Oh, Doug's got something.
What if, rather than asking if you're a Washington resident, we asked, do you receive care in Washington State?
Oh yeah, we can do that. But if they say no, do you wanna remove
if
participants or how?
If no, then I don't think we will want to hear from them.
Okay, we can ask that question. All right, so let's switch to the expert survey here. Let me put it up here. Yeah, okay. Hopefully it's coming up on your screen. Okay, so it's kind of similar flow. We have the demographic questions here. I'm hearing a lot of like background noise somehow. I don't know where it's coming from though.
Might be you, Eileen. Yep.
Okay. All right. Okay. Yeah. So again, it's a kind of similar flow to patient survey, but this is targeting the medical experts, asking the demographic questions first. Kind of similar questions: what's your name, email, do you practice in Washington, do you provide care to patients living in Washington? Yes, no. Oh, Doug, yeah, you have a hand up.
Yeah, so just to start us off, can anyone just click a link on our website and fill out this survey?
Yes, I think this survey will be posted on our website, but we may have to do some active reach out, like getting some mailing list from, I don't know, like Board of Medicine, Board of Pharmacy, so that you can, yeah.
Well, and I wonder, like, I mean, can anyone just say, like, you could just fill out this survey and say, oh, I'm a physician, I treat this disease. I mean, I guess, like, we don't have any way of knowing if there's, of verifying any of the information.
Yeah, I mean, there is a level of trust, you know, involved in some of this stuff. I know some of the other states have done surveys, and you know, some of their responses were, you know, from targeted groups, and so I mean, there is a level of you know, things that as you're putting out information and gathering stuff back, you know, there could be not everything is maybe exactly the people that you were hoping to reach, or accurate.
I think it's fine that anyone can fill it out, and you know, maybe we'll probably get some good information from that. But I think the real key is that we do target those. I guess, like, if there's a professional society of providers in this disease area or something like that, because I think that those are the ones that we have that have credibility, where we'll really be curious of what the responses are. So reaching out to them, I think, is important.
Yeah, we'll find a way to reach out somehow to the experts. Yeah, and we'll have to learn from other states as well. But yeah, I just want to make sure we have the questions ready for that. And okay, so yeah, so the demographics, just asking their profession, medical specialty, and yes, do they provide care for the patients with that certain condition that we are interested in? And then how many patients in a typical month? How many patients with a specific medication we're selecting for affordability review in a typical month? So these are the demographic question, and some practice setting questions here as well. Like, what kind of setting are they practicing? And what is the patient population in terms of the insurance coverage, and whether they are considered as a 340B covered entity or not. So just this is the basic, you know, demographic info. And the meat of the question is here, for the affordability. Have you ever recommended drug X to your patient? Yes, no, I think it just kind of goes to their specialty as well. And then, have you ever had any hesitancy recommending the drug due to concern on the affordability? Yes, no. What is the percentage of patients who do not immediately initiate the drug because of a concern on the cost or the insurance coverage? What is the percentage of patients initiating the drug? And I guess the other portion is the patient not initiating the drug that they're recommending. And issues with adherence, yes, no, or the percentage we're asking actually here. And what is the percentage of patients who discontinue the drug or need to switch when the affordability is a concern. And also what is the administrative burden of the drug. So yes, it's possible the patients can afford it because they have this patient assistance programs or coupons, etc. But for the clinician standpoint, do they have any administrative burdens that they have to file the paperwork or have to do some step therapy for the insurance approval? So that's a question we are adding here. And kind of similar questions here on the coupon and patient assistance programs. The coupons typically available for the patients or not. Any issues with it? Similar with patient assistance programs, is it the program available for the patients with affordability concerns? What is usually the percentage of the patients using it? Any difficulty with approval? Yes, no. How timely the approval is for the initiation of the drug. And if there's any delays, how long it usually takes. Yeah, the eligibility concern for the patient assistance programs. And the last one is the free comment. So these are the questions we have for experts. Just want to hear from you. Do you think these are the kind of hitting the points that you wanted to ask, or you have other questions to experts?
One thing that came into my mind was like some of the questions refer to the condition. And as Hung noted, a lot of these will have multiple indications, and so those
yeah, that's
need
right.
Need to be phrased in a way like,
okay, yeah, have to.
how many patients do you take care of who might be candidates for this drug? Or something like
okay.
that. Yeah.
So it's for different.
There'll be more drug specific, Doug. What you're thinking?
Yeah. So I don't mean additional questions. I mean the questions you already have.
Okay.
They should be referring to basically, patients who are candidates for the drug, rather than mentioning any specific condition, right?
Okay. Yeah, I got it. Yeah, I'll look through the wording to make it more drug specific rather than the condition where it's applicable. Okay, thank you for the comment.
I just have to throw in, depending on who's filling this out, that like a lot of the docs are not going to have a clue about the percentages, or it's the office
I
staff
agree.
that
Yeah, it might be difficult to estimate. Do you have any, I don't know, suggestion on
well,
how to...
it may be that when you're doing the outreach that you somehow you can be coming from the as the question before the practice, and then the doc will hand it off to the nurse to fill out, or whoever is doing, because I mean, I can just tell you that my role was to do all of this outreach and on trying to get drugs approved or getting the money, and the docs didn't know what happened until so.
I see.
And I'm sure it's that way in a lot of the practices. So, and a pharmacist, I mean, I know that you have pharmacists on the list, but they're doing a lot of this too. So I'm just trying to think about how to phrase it so that it gets filled out.
Yeah.
But that the doc doesn't, it's not all doctor totally oriented, I guess.
That's a good question.
So, well, I'll think about it and try and see if I could
if you can forward me like a good wording to capture that'll be great.
And you're probably, I mean, the pharmacists, you guys tell me it's the same kind of thing, that you do a lot of the work. It's not the doc's not, if they're not going to know some of the stuff that you've done too.
Yeah, so it's
Yeah.
both on the clinic side. A lot of the support staff does the prior auth and patient assistant. So that's a piece, and you're right. The usually the provider won't be involved with that. But they, and the drug selection is interesting too. Sometimes it's not the provider. They leave it to a support staff to help select based on formulary and so forth. So especially say they will have a pharmacist that has like a protocol on hand to help select a drug and so forth. So that's one on the clinic side of it. The pharmacy that fills for these prescriptions also has a lot of information. But those pharmacies can be they're huge, and we're probably unlikely to get any information. Say Optum, Accredo, the CVS. Those sites will have information, but I'm not sure if we're gonna be able to get anyone to fill out that information, just because they're national and they're so big.
All right.
But many of the health systems do have their own specialty pharmacies. I know, here at Virginia Mason, at UW, Multicare, and so these questionnaires can be answered from those sites as well.
I wonder if we should put the phrasing, on the cover page. If you have a support staff helping you with any programs or, I don't know, supply, then feel free to forward the link to them. I think that might be one way to do it as well.
And also just ask the other board members, like, how important is kind of getting an idea of how much prior auth and step therapy these drugs require in setting affordability, like overpayment limits and things like that.
It does not seem important to me.
It's sort of what I was driving towards. Like, I'm not sure, like, if everyone has to do I mean, a lot of everyone's going to require prior authorizations for all these biologics. Everything that's expensive is going to be a yes.
It's 100%.
Yeah. So like, why are we asking it? Like, why do we need to dive and get that information? Maybe further down the list, perhaps, but perhaps it's not relevant now.
Do you want to remove this question then, or?
I mean, we got to cut this. If providers are going to do it, this has to be short, like real easy to do. This has got to be quick, and we got to ask like really, really focused questions to get our answers. And it's got to be something they can do in like 5 minutes or less.
Yeah, the administrative burden will be 1,000 out of 1,000, because that's the biggest complaint. It's on national news. It's everything, right? So I think a lot of these questions, it's redundant, and we know the answer to.
Okay, we can remove this one. And you think
I guess, what are we really trying to learn here? We want to learn again, like, same things I said before, are patients who are candidates for the drug not using it because of the cost, and what are they using instead, or if anything.
Yep.
So are we capturing that somewhere?
Okay, so we can ask that question somewhere. Yeah, here.
That can be a free form question, but
Yeah,
maybe that's
we're saying is that we don't think we need most of this question or a lot of this questionnaire, and to just boil it down to some basic questions. Am I right, guys? Is that what you're?
Yeah, or at least put. I mean, the one that I just mentioned, I think should be like at the very top, right? Because maybe they're going to work on this for 5 minutes and say that's enough and X out of it. And so what else, like aside from that, is what else are we trying to learn here?
I mean, I think maybe like the number of patients that are adherent to therapy or not adherent to therapy due to cost, that might be kind of a driver. Like this is too expensive for my patients to get on appropriate therapy.
Right. And yeah, exactly. Like, have you seen it once or have you seen it 100 times?
Yeah.
Or the alternative therapy, are we going to a second line because the first line is too expensive? Right, because then you're not picking what's recommended due to cost or affordability. So
Okay, let's see. So, if you think of any additional questions, can you send it to me, let's say, by the end of this week, or is that a good timeline, or you need more time?
any more time, Marina? I'm actually out of the country for a couple weeks.
Oh,
Yeah, so I mean it's up to you. I'll try to give feedback, but it's not gonna get done today. I mean this week.
Can we do another and maybe slightly different exercise, like try to figure out what exactly we need out of this survey and maybe, I don't know, and then we can kind of boil these down.
You mean like during the next board meeting or sometime sooner, or
I concur with Greg that we need to try to understand what information what we're trying to do with the survey. Yeah. So I don't know, Mike, if is this a discussion that needs to be on the agenda, or is it something that we can do on a one-on-one?
Yeah, I think let's try, just for expediency's sake, if we can maybe do some one-on-ones and discuss some of this stuff a little bit more, and kind of take it from there and see how everyone's feeling about that. So, so yeah, maybe Marina, what we could try and do is kind of at the beginning of the survey, like, you know, maybe some bullet points of this is, and this is kind of for internal use. This is what we're hoping to get. You know, this is the type of information we're hoping to get and how we think it's going to fit into the drug review. And then we can kind of look through, you know, see if the board members kind of agree with that, and look through and see, you know, do these questions meet this intent of what we want? And if not, you know, we can get rid of them. And if we feel like there, you know, we need some more questions, we can talk about some of those, and then we can take the feedback from the board members, kind of compile it into a new survey, and then send that out to get them, you know, a second round review or feedback. Does that sound okay?
I like that.
I think I don't want to wait till the next board meeting. So having 101 and having time to hear from individually, that'll be great. If they are available. And is it helpful if I email this to the board members for you to take a look at?
Yes, I think that's a good idea.
Okay, all right, great. Okay, I'll email this out so that you can kind of comment on it. And I can compile sort of the consensus among them, and maybe we can discuss at the next board meeting. And that's gonna be more complete instead of going one by one. I think that'd be great.
And I would just echo what Greg said about, if we want people to fill this out, it's got to be 5 minutes, 10 minutes max. And so we have to be really stringent about it. Only gets like a question only gets included if it has to be on there. We should drop everything else. I mean, these are great questions to be great information to have, but it just doesn't seem like it's going to be feasible to get the people to fill this out.
Yeah, I think historically to get good provider response, you have to pay them to do it. I mean, it's hard.
Yeah, reality is really tough for us here in dealing with all the providers.
We'll just pay them with all the extra money we have in the state budget.
Yeah,
Or
right.
we can increase the cost of the drugs and
Sarcasm now, no? All right. Is that it, Marina?
Yeah. Thank you. Thank you for your input.
Okay. I'm sorry it's getting louder here too, so I'm sure you're having a harder time with me. Okay, so it's public comment time. Mike, I'll let you call on people since I don't know what we got here.
Well, and I think we were going to do just a quick update on advisory boards as
Sorry.
well. Oh, no worries. So maybe we can take just like a quick 5-minute break. I know we've been at this for like 2 hours, and then we can do the advisory boards. It shouldn't take too long. We can do the public comment and wrap up. Does that sound okay, Eileen? Okay.
Sure. Let's go.
Okay, great. Do 5 minutes. We'll be back here at like 10:40. Okay. I think we all made it back. So I think we can hop here, Simon, to chat about advisory groups next, and then we'll do public comment afterwards.
Yeah. Hey, everyone. And my part can be pretty short. So we can move to the public comment. If you'll remember when we had set up the advisory group, which is kind of part of a body that will provide feedback as we go through the affordability reviews, we had set up the core advisory group, and with the expectation that we would add on a supplementary advisory group once drugs were selected for affordability review. And so just want to give a preview of where we'll go in terms of recruiting and staffing a supplemental advisory group, how they'll contribute, and that work will take place over the next few months as we actually kick off the affordability reviews. So what new experts to add? When we had written the policies, we had spoken of adding up to 5 supplemental advisors from the patient community as well as the provider community. And we're thinking, we could also add in patient advocates, maybe not those directly receiving cares, but those advocating for them, and then any academics that are specifically focused within that drug category or that drug or the indications treated by the drug. Where to find them? So similar to the survey process, looking at the listservs that we have within each CA, so the Gov delivery listservs, and sending it out, getting any nominations from the PDAB or the existing advisory group members, asking Portal in other states who's on their advisory groups or if they have any experts that they're aware of, reaching out to patient and advocacy groups, both ones that have reached out to us and then sourcing them ourselves, and then reaching out and trying to directly recruit anyone. If there are folks at UW that we know of that are experts in a certain drug or a certain condition, then reaching out to them. And then lastly, how they'll contribute. So like the core advisory group, responding to any ad hoc requests from PDAB or the existing core advisory group. And then ideally, we were thinking having them join in the regular advisory group meetings. And then whatever the outcome of the advisory group's meetings is, if it's a drafted report, then having these supplemental advisors kind of draft different sections according to their specific perspectives. So that's just a kind of a high level overview, but any thoughts or questions?
So I have a question on it. So this is just the patients, providers, this is those experts that you're adding. It's one group. It's not a group of each one of those, right?
Yeah, just one group, one patient, one provider, one patient advocate.
Just wanted to clarify because I thought you were getting too many groups going. Any other questions or comments? Okay, looks good.
Awesome. Thanks, everyone.
Okay. Well, I think that then takes us to public. Well, actually, here real quick before I go into that. So just kind of some general kind of next steps overview. So board members will be reaching out, doing some more one-on-ones and talking about the patient surveys. We have our list of drugs. One of the things that we, per the statute, we're required to do is post those publicly before we start doing the actual drug review. So we'll need to do that on our website. And then over the next couple of months, the big things that we're going to be working on then are getting these forms finalized so we can start doing data collection on our first 2 drugs and sending those out. And so we'll kind of keep you posted on how that's going, as well as getting these surveys finalized so that we can look at how to do them. Simon talked about also then getting our advisory boards fleshed out now that we have our drugs selected, and then working on getting feedback from those. So the next few months, there's going to be a lot of basically data collection and trying to put those pieces of the puzzle together and gathering feedback from various sources. So we'll kind of keep you posted on how that goes, depending on where we're at come September. I'll reach out and chat with the board members. Maybe not having the September meeting if we still just really haven't gotten any substantial data back, or we're in the middle of that, or maybe a short one virtually if we're just doing updates on how our data collection is going. So again, I'll chat with you kind of more in our one-on-ones to get a feel of how things are going and where we're at and what we want to do. So that's just kind of my general where we're at and kind of our next steps over the next couple of months. So any questions, comments on that? Okay.
I have a question about the overall list that the board members wanted to see. So do you all want that like on the dashboard, or do you want it as an Excel file?
I think it should be on the dashboard, right? What do you guys think?
Just a separate tab.
Well, the way the current tab is, where when you toggle the all option for biologic, that just basically appends the 2 lists, but doesn't re-rank them. That list, when you filter by all for all, it should be a re-ranking, I think is what we're saying, right?
Well, no, because last time there was a comment that someone wanted to see like both of them at the same time for the visualization, so you could like compare the graphs, the information in the graphs. So if I made it overall, then you wouldn't be able to do that. But is that something that you all now want to change to overall?
Wouldn't the information in the graph still be the same? It would just be the order of the drugs on the ranking that would change. Is that accurate?
Right, but before, I think you all wanted to see both of the lists together so you could compare both of them on the graph so you can like see all 50 bars or whatever. So if you still want that, then we can do a separate tab, or if you just want it to change to the overall, we can do that too.
I guess there is.
I mean, maybe just because to keep with what we'd asked for previously, maybe keep that and then just add another tab might be the easiest. Just kind of from a operational standpoint.
Yeah, I agree with that, and I also think I take the point that there is still value in having the appended list that we have now, because that way it does allow us to see all of them side by side. So I agree. Just an additional tab would be good.
That okay with? Yep. I think that's a good idea to do it that way. Greg or Huang, any comments?
Well, that's fine. I mean, just add on to it.
Yeah, I'm okay with that too.
Okay. Great. So let it be written, so let it be done. Okay.
Well,
any other
public
questions?
comment, right?
Okay.
So who do we have for public?
We have Daria right here. She can be our first public comment, and then we can go to the people on the web if there's anyone else.
Thank you so much. Happy to be here in the room today. Exciting. Daria McGrew on behalf of Pharma for the record. Appreciate the good conversation today of the board members, always thoughtful in your deliberations. We ask that the updated new manufacturer data call template be posted to the website so that we can review and comment before it's finalized and official. Same for the new materials, the provider survey and the patient survey. Those have not been publicly posted at all yet, and really think that they should be posted for public comment officially with a notice and comment period for patients and providers to respond. Haven't reviewed them yet, but just by way of example, in Oregon, there was comments from patient groups saying that their original survey didn't allow for patient groups to respond. So your survey, it suggests that your survey should allow for both. You will have patient groups that are national groups that represent patients all over the country that do have important information that they will want to provide, particularly when you're talking about a rare disease or an infrequent disease. There might not be that many people in Washington tuned in, willing to spend the time to submit the survey, but you will have patient advocacy groups that are very well informed on the issues that will want to respond. So suggest that you allow for both of those, but really I think the groups themselves will want to comment. I just remember that being a comment in Oregon that came up recently. That's everything from me. Thank you very much.
Great. Thank you so much, and that's a really great point and comment on that, so thank you very much. Okay, Simon, anyone else online?
Oh, Seth Griner. Here. Go to mute.
Go to the top. There we go.
Good morning.
Good morning.
Morning, this is Seth Griner. I'm with the National Multiple Sclerosis Society. Thank you so much for the public comment period of this meeting and for a robust conversation. I would just like to second Daria's remarks about the importance of including the patient advocacy community in public comments. As referenced, the Oregon Prescription Drug Affordability Board had a couple of hiccups involved with their public commenting from patient advocacy groups. It is an important voice for all Washingtonians, and we thank the board for this robust conversation and look forward to commenting from the patient advocacy perspective. Thank you very much.
Great, duly noted.
I received an email of another commenter, but I'm not seeing hand raised. Okay, Vanessa Lake, then. There we go.
Hello, my name is Vanessa Lathan, and I'm speaking on behalf of the EACH Coalition and Patient Inclusion Council, a novel coalition that brings together patient organizations, caregivers, and people living with chronic conditions to advocate for patient-centered drug affordability policies. Throughout the affordability review and UPL process, it's essential that the board include strong input from patients and advocacy groups. Hearing directly from those who rely on these treatments will help the board understand the real-life impact of its decisions and ensure the board is addressing the true patient issues. At the end of the day, affordability should be about whether people can get and stay on the medications they need, not just what insurers or states pay. To that end, we encourage the board to establish a clear, thorough, and patient-friendly process for gathering public input on the drugs selected for the affordability review. We have participated in the patient input process put in place by PDABs in multiple states. While we applaud their efforts, we also observe their flaws in their approaches that limit their ability to adequately engage patients and caregivers. We have included many recommendations to the board in our written comments that we encourage the board to review in full. In addition, we offer our coalition, its network of patient organizations and patients themselves, as a resource to the board on the development of patient-facing materials and establishment of patient outreach best practices to hopefully mitigate some of the obstacles encountered by other PDABs. Finally, as the board continues the affordability review process, we encourage the board to establish clear affordability framework that centers on patient costs and the value of medications to individual patients. We encourage the board to take the complexity of each individual into account when deliberating on affordability reviews and not treat therapeutic alternatives as interchangeable. Thank you for your continued commitment to improving drug affordability in the state of Washington. We appreciate the opportunity to provide this feedback and look forward to continuing our engagement with this board.
Great, thank you very much. Yeah, we'll make sure we take a look at all of your comments that you sent. So. Okay, anyone else? Okay. Well, thank you very much. And yeah, now we've got a lot of stuff, work to do ahead of us in the next couple of months. But thank you, board members, for your time, and we'll be in touch soon.
All right. Well, thanks, everybody.
Thank you.
Thanks,
Have a
everyone.
good.
Yeah.
Take care.
Bye.